Assalamualaikum. Today I will present the effect of uncorrected compound hyperopia with astigmatism on the visual performance. According to WHO in 2015, refractive errors such as myop, hyperop, and also astigmatism are the leading cause for moderate to severe visual impairment globally, 160 million, and the second most common cause for blindness, which is 7.4 million, that affect all age group. So the causes can be multifactorial, which is genetic from the inherit from the parents and also the close relatives such as sibling, and lastly, which is the environment such as the visual demand. Next is the symptom such as blurriness, headache, and also eye strain. Next, so this is the patient case history. There is two chief complaints. Firstly, troubling bilateral headache, where the frequency is gradual, onset is in the last 3 months, location is bilateral frontal part, duration is constant but increased with prolonged near work associated with asthenopia. The patient relief with painkiller and sleep, and quality is mild. Next, the dryness and grittiness. The onset is few seconds, location for both eyes, duration is intermittent throughout the day, especially in air-conditioned room and during windy day, associated with mild discomfort, and the patient relief with blinking and closing the eyes. From the chief complaint, I'll come up with 5 differential diagnoses, which is the uncorrected refractive error, myop, hyperop, and also astig. Second is binocular vision problem, which is AI and CI. Third is the dry eye. Fourth is the medial opacity, which is cataract. And the last one is the pathological. The first animal finding, which is +1, on the right eye of the patient reduced 2 lines only, which is SID9, where normally patient will reduce 3 to 4 lines. For near visual acuity, the working distance is quite close, which is 30 cm, where the range is 30 to 40 cm. For near point of accommodation, normally for 20 years old is need 9 cm, which this indicate that the patient might have accommodation insufficiency. For near point of convergence, they may height slightly higher, where the break is 5 cm plus minus 2.5, recovery 7 cm plus minus 3. From subjective reflection, it shows that the patient have high hyperopia and also astigmatism. For amplitude of accommodation, the value shows that is lower than minimum expected value, which is 10 diopter, which indicate that the patient might have accommodation insufficiency or maybe due to the refractive error. Next is MPC. There is slightly improvement after the correction with the subjective reflection, which is so that the patient do not have convergence problem. The patient have high NRE and also low PRE, which indicate that the patient might have accommodation insufficiency. MEM retinoscopy may indicate that the patient have lack of accommodation. For Schirmer test, 6 mm in 5 minutes indicate that the patient have moderate dry eye, where normally more than 10 mm in 5 minutes for severe dry eye is less than 5 mm. 3 seconds for tibat is an amount, where normally for action is 5 seconds, which is this is confirmed that the patient have dry eye. From the clinical analysis, the patient have no convergent insufficiency, medial opacity and cataract since the lens is clear, and also pathological since the posterior of the eyes is normal. For final diagnosis, the patient have compound hyperopia with astigmatism for both eyes. For right eye power, they have plus 1.25 minus 0.5 times 180. For left eye, is plus 1.5 minus 0.25 times 180. The patient have moderate dry eye for both eyes from the T-BAT value and Schirmer value. So the patient is suspected with the accommodation insufficiency since the patient have low EA, high NRE, low PRE, and also high MEM retinoscopy. For short term, we will prescribe the spectacle with full power. Next is lens and frame design, where the durable lens and such as polycarbonate, study frame such as plastic, and anti-reflective coating. Next is the education, which is spectacle adaptation, visual hygiene, and also use of the eye drop. Long term, which is TCA 2 to 4 weeks to meter VA, adaptation to spectacle correction, recheck the EA, NRE, PRE, and also MEM retinoscopy. The patient should be able to adapt with the spectacle correction, doing the new task comfortably without complaining, and reduce dry eye, and improve the binocular vision, which is AE, NRA, PRA, and MEM retinoscopy. So that's all. Thank you for watching.